Welcome everybody to our symposium, Decision Making About Pain Across the Lifespan. My name is Randy Grout. I'm from Indiana University and I'll be chairing this session. For today we have 4 speakers and panelists. I will introduce them now as well as their titles, and then they will each speak in turn. We will have about 10 minutes for each talk, and we will hold our questions until the end, and we hope to have about 20 minutes for a question and answer period with individual speakers or the panel as a whole at the end. First, we will hear from Lynn Gauthier from Laval University, and she will be speaking on cancer pain management across the adult lifespan. She will be followed by Christine Chambers from Dalhousie University, and she will be speaking on partnering with parents to improve pain management in children. Following her, we will have Isabel Jordan, who is a parent and patient partner, and she will be speaking on medical decision-making and pain. It's a matter of trust. And our final speaker will be Kharay Jalal from the University of Pittsburgh, and he will be speaking on pain management and the opioid epidemic. Lynn?
Thank you. Thank you for the introduction, and thanks to the organizers for the opportunity to come and speak to you about pain management across the adult lifespan with a focus on older adults. So pain is really one of the most common and feared symptoms in cancer, and it's highly prevalent across the cancer continuum. About 55% of patients undergoing active treatment experience pain, 39% of post-treatment survivors experience pain, and 66% of people with advancing disease or at the end of life experience pain. Unmanaged pain is really associated with profound impacts on multiple domains of quality of life, including physical, psychological, social, and spiritual well-being. And it's also associated with desire for hastened death and suicidality. So throughout this talk, I'm going to be focusing on the bottom right-hand corner of the arrow because although some of the issues are consistent across the cancer continuum, such as the persistent undermanagement of cancer pain in older adults, other issues such as treatment decision-making are different. So in terms of whether there are age differences in the prevalence or intensity of pain, the evidence is really mixed. The bulk of the evidence seems to suggest a small decrease in the prevalence of pain, but the clinical relevance of this is unclear, and this may actually be confounded by cognitive status or a person's ability to self-report their pain. In the studies of pain intensity, it's often unclear if patients without pain are included in the analyses, but among the most methodologically strong studies, intensity does not decrease with age. And importantly, younger and older people are equally vulnerable to the negative impacts of pain, such as depression and activity restrictions. So how do healthcare providers make decisions about pain management? The World Health Organization's cancer pain relief guidelines are really the cornerstone of cancer pain management, and they've made the most significant contribution of all published guidelines. And so these arose as a result of a meeting in 1982 in Italy with participants from the WHO Cancer Unit, the International Association for the Study of Pain, St. Christopher's Hospice. And the goal of the meeting was to develop new public health policy on cancer pain relief. And this meeting really arose as a result of the recognition of the worldwide public health crisis of the undertreatment of cancer pain. And so they wanted to develop a simple regimen which could be disseminated rapidly and cheaply in low-income countries. So the result of the meeting was the WHO analgesic ladder, published in 1986, updated in 96, translated into more than 22 languages. And it suggests that healthcare providers should base pain management decision-making on the severity of the patient's pain. And it also suggests that analgesia is adequate when there's congruence between the patient's reported level of pain and the potency of the prescribed analgesic. So it starts off by suggesting that with a report of mild pain, a non-opioid plus or minus an adjuvant should be tried. And by adjuvant, I mean something like a tricyclic antidepressant or a gabapentin, something like that. With persistent or increasing pain, a weak opioid, plus or minus a non-opioid or adjuvant, should be tried. And then with persistent or increasing or moderate to severe pain, a strong opioid plus or minus a weak opioid or non-opioid or adjuvant should be tried. Oops, we're not moving. Robin, I think we're stuck. Don't point at the screen. Oh, and now we're gone. Okay, thank you. So, how effective is cancer pain management? It's been suggested that the WHO ladder should relieve pain in 70 to 95% of patients. But in order to evaluate this claim, we really need to understand how we're measuring the adequacy of cancer pain management. And most people do this with something called the Pain Management Index. And so this assigns scores to the potency of the strongest analgesic prescribed to the patient, and it assigns a score to the patient's report of worst pain intensity in the last 24 hours on a 0 to 10 numeric rating scale of pain intensity. So for example, if a patient is reporting severe pain, 8 out of 10, and they're prescribed fentanyl plus or minus gabapentin, they would receive a score of 0. So they would receive a score of 3 for their worst pain, a score of 3 for the fentanyl, and the PMI is the result of the worst pain score subtracted from the analgesic ladder score. So it's been suggested that people with inadequate analgesia have scores less than 0. So how well are we managing cancer pain? The answer to this question comes from a few systematic reviews. This particular one looked at studies, 44 studies using the Pain Management Index, and they found that almost half of patients with cancer pain were undermanaged. The systematic review was updated about 5 years ago, and although they found that the prevalence of undermanagement had improved somewhat, still a third of cancer patients with pain are undertreated. And so what about older adults? So we know, starting from about 25 years ago, that older adults are more likely to be undertreated compared to younger adults. And so this is a graph showing the percentage of undertreatment in patients with advanced cancer. And you can see that the prevalence of undertreatment increases with advancing age, especially if you're a woman. This graph shows cancer pain management among older patients in nursing homes reporting daily pain. And you can see that among adults aged 75 to 84, they're less likely to receive a level 3 analgesia, as well as adults age 85 and older. And an alarming 30% of adults age 85 and older receive no analgesia at all, despite reporting daily pain. And so this really hasn't changed over the last 25 years. And we have some data now, actually, from cancer survivors showing the same trend. But these were studies of patients with advanced cancer and pain. This was actually my PhD. And this was a study of age differences in pain and adaptation to pain in people with advanced cancer. It was funded by CIHR and CFI to Lucy Galiesi, who was my PhD supervisor. And so the data that I'm showing you were published over a number of different studies, including one that is just about to be submitted. So again, these were participants with advanced cancer and pain. We constructed 2 age groups, matched for sex and primary tumor type. And so these were the pain management index scores for everybody in the sample. And you can see that the majority of the people in the sample looked like they were adequately treated, with just 15% in the undertreated range. It's important to keep in mind that this sample was primarily recruited from outpatient palliative care clinics at an academic tertiary cancer center, so they were receiving specialist palliative care. However, there was a significant burden of pain in the sample, with just about 40% reporting moderate to severe average pain, about 65% reporting moderate to severe worst pain, and about 50% reporting moderate to severe interference. So this really doesn't seem like adequate pain management, and so perhaps the PMI is maybe not the best index. And importantly, older adults and younger adults had an equivalent burden of cancer pain, so it didn't differ. However, consistent with decades of literature, older adults were less likely to be prescribed an opioid, and these were their WHO analgesic ladder scores. And you can see that there was a trend for somewhat more level 1 prescriptions in older adults and somewhat fewer level 3 prescriptions in older adults. So some of the reasons that we know may contribute to this undertreatment of pain in older people include known healthcare provider known gaps about pain in older people. Some beliefs that older adults or good patients don't complain about pain, and myths held by both patients and healthcare providers alike that pain is a normal part of aging, it's a normal part of cancer, and analgesics are inherently addictive. And so you can see how this would impact on a person's willingness to spontaneously self-report their pain. But we know that assessment is likely a major culprit. Older adults are less likely to be asked about their pain. Even when they are asked, they're less likely to be believed. We know that healthcare providers tend to underestimate pain in older adults compared to younger adults. And there's still the problematic use of assessment scales that are not validated for use in older adults. And so obvious solutions include education, including improving healthcare provider skills for comprehensive pain assessment and the proper choice of assessment tools that are validated for use in older patients. And so there are a number of different guidelines available. This is just one, but there are many. And so there are some important remaining questions about implementing these guidelines in care. Is the WHO ladder the best choice? And remember that it's been suggested that it should relieve pain in 70 to 95% of patients, but it's never really been properly tested, and it's missing a number of important things that should go into treatment decision-making, such as the pathophysiology or the characteristics of cancer pain, whether it's nociceptive or neuropathic, and how that should contribute to treatment decision-making. Importantly, age-tailored recommendations are missing, and this is important because pain management is complex in older adults for a number of different factors, including but not limited to decreased renal clearance, comorbidities, polypharmacy, and we know that overtreatment is problematic and could lead to cognitive impairment, balance issues, and falls. Other important factors that are not considered are patient values for pain relief against side effects, their preferences for care, and determining clinically relevant outcomes for patients based on life stage. And of course, the important advances in shared decision-making that have been shown in other fields have rarely been applied in the cancer pain management literature. So this is where I end, and I thank you, and I think we're gonna take questions after. Is that right? Okay.
Hi, everybody. I'm Christine Chambers, and I'm here to talk to you about our work partnering with parents to improve children's pain management. Pain is also an issue for the younger age of the life spectrum. We know that children experience pain from procedures very frequently, including vaccinations. And chronic pain is also a significant issue for children. 1 in 5 children, so the same as with adults, 1 in 5 adults experiences chronic pain on a regular basis. And we know that 2/3 of children with chronic pain will go on to become adults with chronic pain. So it's very important that we do a good job at managing pain in the pediatric population to help reduce some of the burden associated with pain later in life. I'm a clinical psychologist by training, and most of my empirical research over the last 25 years has focused on the role of parents in children's pain management, what parents say and do, and how that impacts children's pain. And you can see in this picture here that although it's the baby getting the needle, it's the father who is feeling the child's pain. And it's very much that relationship, again, what parents say and do, and how they are supported in helping to manage their children's pain that my research has focused on over the last number of years. We have a really robust research literature on effective strategies for pain management in children. Our knowledge has grown tremendously over the last 30 years. And while there are still gaps and we still need more evidence-based solutions, the reality is that the majority of children never benefit from the evidence-based solutions we already have published literature on. And nowhere did that sort of evidence to practice gap become more evident to me than in my role as a mother. So my 4 kids have taken me to the front lines of pain management with their different procedures and hospitalizations. And there were so many times that I had to advocate very strongly for my children to receive what I knew to be evidence-based pain management. My husband's an anesthesiologist, so together, like, we are an interdisciplinary pain management team. But not every child has the benefit of having pain management experts as parents. So what about every other child? This evidence to practice gap has been highlighted in a number of places, and there are estimates that show that it can take as long as 17 years for research findings to trickle their way to the front lines and improve practice and health outcomes. And we know it's a leaky pipeline. Only about 14% of research ever finds its way into practice. And if you think about 17 years, that's an entire childhood. So a whole generation of children ends up missing out on the benefits of evidence that is already generated and published and known. A couple of years ago, I did a fellowship as part of my sabbatical on media and advocacy and policy, and I decided that I wanted to reach parents and work with parents directly around improving pain management in children, because nobody is ever going to advocate more strongly for a child than a parent. And parents want to help, but they often just don't know how to be part of that solution, and often aren't included in their children's healthcare team. And at the time, I was learning on my fellowship about the power of social media as a way to reach and engage with parents. And we know that parents are very high utilizers of social media, both mothers and fathers. You can see here that a large proportion of parents are going online to find parenting information, to receive a support on an issue, or to directly ask some sort of question. So as part of my fellowship, I completed or produced with a communications company a YouTube video for parents about needle pain management. And in the video, a little girl, you can access this just by Googling It Doesn't Have to Hurt on YouTube, she shares strategies for how to make needles easier. We worked really hard on this video. It's just 2.5 minutes, and secured funding for it from a provincial funding agency. But we put all of our money into the sort of production of the video, and I didn't really think much about how do you get it in the hands of people who need it. So I learned a really important lesson, which is if you build it, they won't necessarily come. And we researchers and health professionals, you know, most of the time we create really boring knowledge-sharing tools. Our pamphlets and videos are usually terrible. They have good content, but they're not marketed in a way that makes them look good to parents. And we certainly don't have the reach to get it in front of people. You know, we send it to a few email listservs, and that's about the extent of our reach. So I started tweeting as a way to reach and engage with different influencers, including health reporters and online parenting media like Erica M's YummyMummyClub.ca, which is an online Canadian publication with a reach of over 6 million Canadian moms a month. And you know, that really opened my eyes to the idea of partnering. Instead of trying to do things for parents, could we partner with parents to improve pain management in children? So Erica and I created or wrote a operating grant to the Canadian Institutes of Health Research. It was a partnership to work together, a scientist and media with a real connection to Canadian parents, to create a compelling digital content campaign in which we shared evidence-based research in an engaging way. We partnered on It Doesn't Have to Hurt, which was a 12-month social media campaign. And the way it worked was that we had a very active parent partner program. Isabel, who will be speaking next, was part of that, who helped us identify areas of information need for parents, but so much more as well. Our researchers created evidence summaries. YMC created parent-centered content via their media influencers, most of whom were parents. And we had various partners who amplified dissemination. This just gives you an idea of some of the content, blog posts that were posted on the YMC site and pushed out to their extensive network of parents. Social media images, very simple, like this one, breastfeeding and needles equals it doesn't have to hurt. That's dozens of randomized trials summarized in systematic reviews, but messaged in a very effective way for parents. We had YouTube videos for parents in which parents shared stories embedding evidence-based content about children's pain. And Twitter parties, where parents could come online and directly engage with scientists and ask questions. We trended #1 on social media on a number of occasions, which is someone who's been trying to get people to talk about children's pain management for 20 years, was very exciting. I'll just show you this brief video that'll give you some perspectives from the different stakeholders involved.
In the world of medical research, it can take up to 17 years for research findings to be used in everyday life. That means that research that can help children who are suffering in pain sits on the shelf while their parents desperately search for answers. It Doesn't Have to Hurt is a groundbreaking social media initiative that helps make evidence-based medical research available to those who can benefit from it instantly online. Because of this unique science media partnership, the conversation between scientists and parents took off around the world on social media using the hashtag #ItDoesn'tHaveToHurt. It made such waves on social media that Twitter Canada invited everyone involved in this special project to their headquarters to celebrate, and also to use their Twitter Live video app to reply to parents' questions about their children's pain live. In today's world, success is often measured in view counts and likes. But in this case, what matters most is the impact of the initiative on parents, children, and researchers.
This program is so important to get information that is evidence-based out to moms like me all across the country, all across the world. So we have a way to feel empowered.
I'm able to reach thousands and millions even of parents who are able to then improve their outcomes and reduce their child's pain.
Parents of children who are suffering needlessly in pain are absolutely desperate for information that's going to help them to ease the pain of their children.
I feel like a program like this, first of all, allows people going through chronic pain and just any type of pain to let them know that other people are going through that, because often it's kind of like the silence, that thing that you don't talk about.
It's not just about busting the silos amongst organizations like the children's hospitals, for example, but it's also across the sector. So not just the big children's hospitals, but connecting with the community hospitals, the children's rehab centers, the home care agencies, so that everybody has this information.
It's all about sharing it, and like the more knowledge we have, the better we can help our kids, or even just be better advocates for our kids.
Well, look, it's the dream of every university that your faculty are not just great teachers and researchers, but they're engaged with the public, so that we're bringing that research to life, and that research is informed by the public, as it is tonight with the questions on Twitter.
This initiative has been a catalyst for changing the way scientific research is shared with the people who need it most. And the conversation isn't stopping now. Together, we will continue to harness the power of social media to help children and the people who care for them know that it doesn't have to hurt.
So our goal is improve pain management by partnering with parents to make a difference. Thank you.
So as I start, I would like to invite all of you to take a moment and think about your lives and think about, in your life, who do you trust? Your family, your best friend, your doctor. Look around your virtual life as you sit here. There's nothing like an acute healthcare crisis to happen to sharpen your focus where your circle of trust begins and ends. And there's nothing like an ongoing chronic health problem to make you realize that trust can be easily lost and not so easily won again. Today, I'd like to talk to you about our family's experience with trust and loss of trust and how it got tangled up in our son's experience of pain. how trust can be lost, how difficult it can be to make decisions when your trust in your healthcare providers and yourself has been shaken. But first, oh, I forgot I have that. I can look down there. But first, I think you need to know a little bit more about myself and my family. Who I am is a mom to these two kids, Zach and Evie. Zach just turned 17 last week, and Evie is 14. When Zach, our oldest, was born, he was small, but he seemed pretty healthy. It was only as he grew from infancy into toddlerhood that we began to have questions about his health and his development, and we got thrown into the medical system. We spent about 3 years, from about the age 1.5 to age 4.5, going from doctor to doctor and specialist to specialist, looking for answers, trying to find out why he was different from other kids, why he seemed to experience the world in a different way, and why he had challenges that others didn't seem to have. Some clinicians metaphorically patted us on the head, told us to stand down. They couldn't see anything wrong with him from their particular silo. Others took a more comprehensive approach. And while they couldn't help him and couldn't find any answers, they at least referred us on and tried to help us find somebody that could give us an answer. In the meantime, in order to make this happen, Zach was going through medical test after medical test, experiencing needle pokes, procedures that only seemed to make him more and more fearful of the medical system. We were asked to hold him down, and with a tinier than usual body, he could put up a hell of a fight, requiring 6 or 7 people often just to get measured. Taking him to any new doctor was a frightening experience for him and made us wary of any new testing. But while we thought it was necessary, we grew fatigued with no answers forthcoming. What seemed apparent as we went through all of this is that he yelled louder, he cried harder, and being touched, manipulated, and tested felt like torture to him. At 4.5, we finally ended up at medical genetics. There we were told some reassuring yet shocking news. Reassuring because we were told that after all of these years and all this time, we had been right to pursue this path of inquiry. And shocking because despite all of that, and despite the fact that they suspected a genetic cause that would likely tie all of these things together that we were looking for, they couldn't put a name to what he had. He was uncharacterized, he was ultra rare, it was the day of his undiagnosis. So when Zach was 6, he was 4.5 when he had his undiagnosis. When he was 6, the other shoe dropped, and we found a very large tumor, very rare tumor, in his jaw, a desmoplastic fibroma of the bone. The only option for treatment, because this was so rare, was a radical resection and jaw reconstruction. This would be a daunting experience for anyone going to the hospital. But for a kid with an uncharacterized rare disorder that impacted how he felt pain, how he reacted to medications, and how he experienced the world, the thought of a 14.5-hour surgery, an unspecified time, but probably an extended stay in the ICU, well, we didn't even know how to start to prepare ourselves or him. When you add the fact that by then he had already had quite a severe needle phobia from all of the other procedures and testing he had done and how much he had experienced pain, I can tell you my husband and I were very nervous about the experience to come. Our main experience of healthcare up to that time was that we weren't believed. This was our main intersection with the healthcare system. We didn't know how we would advocate for his care while we were in the hospital. During all the needle pokes and IVs he had had up to that time, I tried to advocate for him. I tried to explain that he definitely was feeling pain, even when he had topical anesthetics that seemed different from other people, and all my concerns were always swept aside. What was going to happen in the ICU when everything was heightened, when there would be more? We had nowhere to turn, we had nobody to ask for help, and we needed to learn on our feet when we were there. Well, after a 14.5-hour surgery, we spent a harrowing 8 days in the ICU. Either myself or my husband, more often the both of us, were constantly at bedside with him. Zach had his tumor removed, along with his right mandible down to a 6-year molar. A graft from one of his ribs was used to reconstruct his jaw. He needed a tracheostomy because the swelling compromised his airway. So he couldn't communicate with us, except for with his eyes and with his body language. My heart felt broken from all of this. And the only people that could really communicate with him were myself and my husband, because we were the ones that knew him best, and he didn't have any words, and he couldn't write anything down to communicate. We knew that he was in agony whenever IVs were changed, whenever new meds were given, whenever his catheter had to be changed, even though analgesics and light sedatives were used. Whenever we had to suction his trach, he would look at us, wanting to breathe, yet wanting us to stop at the same time. And here's the thing, while Tyler and I, my husband and I, knew he needed more pain control, the healthcare providers there wouldn't believe us, and they wouldn't listen to us, his parents that knew him. And we couldn't figure out a way to convince them of the truth of Zach's experience. I honestly had never felt and have never since felt like such a failure in my life because I couldn't do anything to protect him. I'll paint a picture. We were in a strange and hostile environment, sleep-deprived, constantly on the brink of panic, looking for an ally to help us do the right thing. But we learned by that time that the healthcare providers that were there just didn't believe us or trust us. When things went wrong, or issues came up, and if you've ever been in the ICU, you know that this is a very common occurrence, we didn't know where to turn to help us make the right decisions in his care. We ended up with one ally, sort of. There was one nurse who, like everybody else, didn't believe us when we told her the truth of his experience. But at one point, she finally could see with her own eyes that he was experiencing pain when it was unexpected and when others wouldn't have. And after that, she became a great advocate for him and told others to believe us. But still, even though that happened, it was from her seeing, not her believing us as his parents. And regardless of the outcome, that does make a difference because we still weren't believed. So here's the thing. Is there fallout from this beyond that ICU experience? Well, of course there is. The fallout is trauma. And trauma makes for more trauma. The memories of not being believed is mistrust. The fallout of mistrust is that calculation every time we go in to see a healthcare provider. Do we tell the whole story? Will they believe us? What do we give? What do we hold back? The fallout of parental complicity, of when we had to hold Zach back for procedures that had to happen without enough pain control, is, does our son trust us? And how do we get his trust back? And that was facilitated by the healthcare system. All of this together doesn't breed an environment that makes for our family making good decisions. Clinic visits become charged affairs, become full of stress even more than they have to be. Every new physician we go to, and there's lots of them in a kid that has a complex health condition, are charged, and everyone, I do a calculus in my head. How much do I tell this one? When do I tell them? How do I tell them? Do they enter our circle of trust? Have we lost the trust? Can we get the trust back? And is it worth it? Do we just cut and run and find somebody new? Sometimes that's easier. And then we can make better decisions. Honestly, it's exhausting. It's more exhausting than the actual health condition. It was initially exhausting for Tyler and I, but now Zach's older, he's 17, and he's the one that needs to make the decisions, not us. And I'll tell you something, he understands that he needs to trust the people that are helping him make his health decisions. And in that understanding, he remembers everything. Thank you for your time.
Hello, everyone. My name is Howard Jalal. I am a researcher at the University of Pittsburgh. My research does not involve directly the pain and pain management, but I do a lot of work on the opioid epidemic and the drug overdose epidemic. And I hope that through this presentation, I can shed light on the mismanagement of pain and the trajectory of the entire overdose epidemic. So I have 2 items on my agenda. Number 1 is the Association of Pain Management policies on the opioid epidemic, and the other one is the opioid epidemic in the context of the wider, broader drug overdose epidemic. So for those who know me, I don't tend to self-promote, but we do have the study that's freely available through Science magazine. We also have free copies available outside that we shed light on the opioid epidemic in the context of the drug overdose epidemic. I'll try to explain some of our findings in the next few slides. So, some of you are familiar with this picture. This portrays the overdose death over time from 1999 through 2016, and by different type of drugs. And I don't know if the laser pointer. So the blue line represents prescription opioid overdose deaths. And you can see in 2010, there was a deflection in that curve. And there are other patterns as well that you can observe associated with some of the policies that has been done. So so in 2006, there was an FDA warning against methadone prescription for chronic back pain. And after that, the green line deflected, which represents the overdose deaths from methadone. As well, in 2010, there was OxyContin reformulation. They made the formulation a little bit more resistant towards abuse. And then you can see there was a temporary reduction in prescription opioid overdose deaths. But at the same time, you can see the bright pink line, that's heroin deaths. After 2010, it increased significantly. And in 2013, the tan-colored line represents fentanyl deaths that has now surpassed overdose deaths from the other drugs as well. So if you aggregate all of these epidemics, you can see a very steady curve that extends from 1999 to 2016. And if you go backwards in time, that process is nothing new, and has been actually in effect before the opioid epidemic started, even before OxyContin was actually approved by FDA. So the process of overdose deaths has been way before the opioid epidemic, and has been before any specific category of patient had been infected by this epidemic. So this particular finding got us very curious. And why is this happening? Can we find a similar pattern in any of the sub-epidemics, like by drug and also by subgroups of the patients as well? So I will show you a few graphs that shows the heat map, what we call heat maps, that show the overdose deaths by age. So on the y-axis, you have age of the individual, and the x-axis, you have the calendar year. And the overdose death is represented by colors. The blue represents lower mortality rate, and the red represents higher mortality rate. And as you can see, over time, the mortality rate has increased quite a bit for the average age group for 40-45. You see a peak in there. But over time, that peak is accompanied by a second peak among much younger individuals that are now surpassing the older age group in overdose deaths. So this pattern is not unique. Actually, there are a lot of heterogeneity by drug and also by demographics. So the rows of this graph represent the different drugs. You have heroin, prescription opioid, methadone, fentanyl, cocaine, and you have unspecified drugs, methamphetamine, and unspecified narcotics and drugs. And in the columns, you have the different type of drugs. You have the overall, the total on the first column, and then you have male, female, white, black, other, and urban and rural. And none of these patterns look the same. And you see a clear, a clear pattern for some of the drugs that you cannot observe in others. So we also looked at this more geographically, and you can see prescription opioid distribution. Overdose deaths is very different, is widely distributed in all over the country, except for the central states, including Texas in the south. And heroin, fentanyl, and cocaine are involving mostly the Northeast and New Mexico. Methamphetamine is more in the Southwest. But somehow, when you combine all of these drug epidemics, you get an exponential curve. So this curve, these maps here represents also the different types of drugs. So each row represents one of the drugs. You have heroin, prescription opioid, methadone, and fentanyl, cocaine, unspecified narcotics, methamphetamine, and unspecified drugs, and by period. So you can see that how the epidemic has spread over time for almost all of the drugs except for methadone. So that's, again, like if you combine all of these epidemics, all of these sub-epidemics, somehow you get a smooth exponential curve. So this is a paradox, and I would like to present that paradox for you in a hope to engage the Society for Medical Decision Making to look for the root causes. Why do we observe this paradox? Why on the surface of it we have a smooth exponential curve representing overdose death, but when you look underneath it, none of the patterns look the same? So the epidemic seems to be rebounding no matter how we are acting against it. Does that mean we are not affecting the root causes of the epidemic, and we are super focused, we are hyper-focused on the one particular drug at a time and one particular age group at a time? So thank you very much.
Thank you to our panelists, Lynn, Christine, Isabel, and Harwe. We will now have time for questions. If you would be able to introduce yourself at the mics and then direct your question, or let us know who you're directing your question to or to the panel in general, and welcome the panel to jump in on any answers also. I'll start off with a question then. And I'll direct this first question to Isabel. Thank you for sharing your experiences. What were some of the qualities of the providers that trusted your medical decision-making as a parent? What are some of the qualities of those providers that you noticed?
I can tell you more about, I think that they slowed down and listened, and just that they trusted that we understood our own experience, that we were embedded in our own lives, and that they could only see a slice of it, so that they had their expertise and we had our expertise, and that they were not, they did not have insight into that.
Excellent, thank you.
Michael Rothberg, Cleveland Clinic. I guess I have a question really for the whole panel, and I guess I'm interested in your take on this. So, as I look at the question about cancer pain and the step therapy for cancer pain and the approach to cancer pain, that really got kind of generalized in the mid to late 90s to all pain, and that we should that we were under-treating everybody's pain, and that we should use the same paradigm for treating everybody. And then we got the opioid epidemic, and as you just presented, if you try to stop prescribing one drug, that's not probably the cause of it. But in terms of policy implications, certainly as a clinician, I feel that my state, my country doesn't want me to prescribe opioids for anyone, except maybe people with cancer, because cancer is special. They're like in a separate category. And one of the things is that, there's this idea that people don't really have the pain, that this treatment of pain isn't really necessary. A lot of these people are faking it so that they can get these medications so that they can overdose and make the country look bad. So really, for any of you, what are really the policy implications of what you've found as a group? And what should we be doing to advocate for the people who have pain who are now going to be denied treatment?
I'll start from the cancer perspective. Where to start? In terms of pain management and palliative care, you're right. There is this perception that cancer is somehow special. People with cancer pain, we should believe them because there's something that we can see on imaging. There are concerns that the way we're framing the opioid epidemic is impacting on people's ability to access care, not only for people with chronic pain, but also people for cancer pain. There's actual evidence for people with chronic pain that the way that we're framing this opioid epidemic is impairing their access to care. There are anecdotes now emerging about the same phenomenon in people with cancer pain. We were just at the World Congress on Pain in Boston, put on by the International Association for the Study of Pain. And there was one really interesting symposium about what the opioid epidemic is globally, or perceptions of the opioid epidemic, or how we interpret what this is. And really, this is kind of, the way that we're interpreting it is sort of a North American phenomenon, where the opioid crisis in low and middle income countries remains lack of access to care, really phenomenally lack of access to care. I guess the other thing I want to say is that when we're talking about this opioid crisis, are we always differentiating people who need opioids for pain management, whether it be chronic pain or cancer pain, versus people who are accessing these drugs outside of, I want to say, a non-therapeutic use, but maybe that's a misnomer in this case because it's therapeutic for some reason, but it may not be for pain. So I think we need to be very careful about how we do this research and how we frame what the opioid crisis is, differentiating out the impacts of the opioid crisis, overdose, death, things like that, people who are accessing these medications for pain versus people who are accessing them outside of the context of pain.
So I would echo a lot of what you're saying. My son also has chronic pain, and as a rare disease advocate, much of our community deals with chronic pain. And I really echo what you say about, I have concerns about how it's been framed in that there are people now being denied the medications that they need, or they're afraid to even try to go access the medications that they need. Being afraid, this is people that I know, being afraid to access emergency care for pain, but also for other issues, whether it's related to their rare disease or not, because of their pain, and just being labeled as drug seeking and not getting care that they need, and having other issues not looked at, because the two things are being conflated into one. And I really think this is something the patient pain community is really trying to work on, and I think would be something really good for the research pain and clinician community should be coming together on, for policymakers to understand that these are different important issues that are not the same.
Yeah, I'll just jump in to say that, I think the opioid crisis really highlights a couple of issues related to chronic pain, and one is that, again, in terms of access to care, I mean, we have, good evidence for interdisciplinary approaches to pain management, but the reality is very few patients have access to that, or even in Canada, we have publicly funded healthcare, but to access a psychologist in private practice, you still have to pay. Same for physical therapy if it's provided outside of the hospital. So, even though we do have evidence-based solutions that are non-drug, the patient's abilities to access those, and so medications have been sort of a strategy that a family doctor who has a big patient load and patient suffering have been able to rely on, and it is challenging when other, avenues are not available. The other thing too is I think we have to be very careful around, the pendulum is swinging too far the other way with not believing patients in pain, and I think we are well past that. Chronic pain is a disease in and of itself now. We understand that from a scientific perspective. I'll just chime chime in with the little policy piece that's going on in Canada. At the beginning of September, there was an opioid summit here, or hosted in Toronto, in which they brought together different stakeholders, and the needs of patients with pain was very front and center as part of that opioid summit. And our federal health minister hosted a roundtable with about 20 different stakeholders. I was there, a number of patients were there to, she expressed her commitment to make sure that in whatever policy decisions are made around the opioid crisis, that the needs of patients with chronic pain will be considered.
So I absolutely agree with all of those, and I think there's evidence in the data about those epidemics, like about the various reaction of the epidemic as a whole to the different policies that were implemented. One thing I want to add to that is for acute pain as well, when for example, a young individual gets have an injury, they get prescribed an opioid, they may get addicted to it, and then there is no treatment. The waiting time is very long, even for private treatment facilities. So I think implementing a policy without thinking about the reaction of that individual and of the community as a whole to how they will act to lack of availability of treatment, and all of a sudden interruption of the treatment without giving them outlets. I think that's the major concern of the epidemic, and we keep seeing this over and over again.
I'm Holly PA from RTI. This is not my area, so I apologize if this is a little bit of a naive question, but I do rare disease research, and recently started a new research collaboration with a rare disease where there are severe communication problems, and there are really striking parent pain worry themes that are coming through. So these parents are very, very concerned that their children are in pain, and they are unaware of it, or they don't know when to intervene and how bad it is. And I wondered if you could talk a little bit about the extent to which the sort of anticipatory worry about pain, downstream pain, impacts this whole relationship with providers and the way that we deal with pain, not pain right now necessarily, but thinking ahead to pain.
World, I mean, there is evidence that, expectation, and we were just talking about that earlier today, Amy, anticipation of pain is predictive of pain down the road. So yeah, I also think in, an area where we've heard a lot of feedback from parents is, how do I assess pain and monitor pain in my child who might have a rare disease or have a cognitive or developmental delay, and pain is not expressed in the way that it normally, quote unquote, would be in a child who did not. And again, I mean, there's been quite a lot of research on developing tools, behavioral assessment measures, but most people are unaware of them, right? They're buried in journal articles and have been presented to conferences to other academics, but they don't actually get in the hands of parents who really need it. So, we need more research in that area, and we've recently put in a proposal, Isabel's part of this, for a knowledge mobilization network. And as we were building this proposal, the needs of patients, from different disease, and rare disease groups, and that have been overlooked. So there is some research there and some, options for assessment and management, but we need to do a better job at making sure patients actually get to use them.
So if I could just add to that as a parent who has a kid with a lot of different symptoms, including pain and nausea, and I've spent my life trying to figure out how to help him and anticipate without, we live a life of uncertainty and trying to figure out what's going to come, and never having had the tools to know what we should be. We were told, be vigilant, but don't over-medicalize, was what we were told, which is a hell of a thing to tell somebody, frankly. And I think the more tools you can give parents to do things in a constructive way without laying more guilt on us is helpful. And a lot of, I think, the language in academic work is unintentionally gives guilt to parents. So I think there's a lot of work that could be done to be helpful in that way. Would you say?
My name is John Wong. I'm at Tufts Medical Center. I'm a primary care physician there, and I've done decision analysis for my research. And I actually have a question for each of you in some sense, if you don't mind. I kind of view policy as a blunt instrument that seeks to move in a particular direction. And accordingly, when I speak with my pain specialists, they recognize this swing in the pendulum, you know, and they share your worry about the pendulum swinging in the wrong direction or excessively for managing individuals who have pain, whatever the cause. So in some sense, policy is a blunt because it targets specific things usually, a specific drug. And so I want to congratulate Havre. I don't know too many folks in this society who've gotten a paper published in Science, so really neat. It seems as when I look at both policy in the various manifestations at the federal level or the state level or a medical society level, they're just, not just, but they're targeting specific drugs and specific occasions with specific screening tools to avoid certain things. And what your data show is, regardless of which state, regardless of what we're doing at the federal level, there's a shift. There's not a holistic approach to whether it's a prescription versus a non-prescription source. And so consequently, we see this rather constant exponential rise. I don't have the answer, but just, you know, you pose the really interesting question, but it's sort of this single bullet, single target without, and I mean, when I listen to, and again, I'm not an expert in this, but when I look at the resources and the ability to access, you need longitudinal care with support, you need more services, you need more beds, you need more counselors, and as a country, we're not funding that. There's some isolated reports, not even at the state level, but at a sort of micro town level is what I would say. And then lastly, but not least, as a physician, Isabel, I just, you know, there's a book called Difficult Conversations. And it's a wonderful book for clinicians because it talks about this disconnect when you're having a conversation and the two of you just don't see each other eye to eye. And it really has to do with, exactly as you said, the lived experience. And when I think about parents with kids who are nonverbal, it's a lived experience that from that, and nurses too, even more so than doctors, when patients, either adults or children, are in the hospital, see that patient on a more hour-to-hour, minute-by-minute basis than we as physicians typically would see them. And they can see things, sense things that I can't and don't know about unless somebody brings it to me. And similarly with some of my older patients who are developing cognitive dysfunction, where again, it's a family member or a spouse that comes in with them, and that's when my antennae go up and I say, okay, there's something going on here that's different, and I hadn't heard it from the patient himself or herself. What I wanted to ask you about, though, is the impact of your son's illness on your daughter, because one of the areas of things we often have overlooked in the past is, I heard very poignantly the effect on you and your husband and this trust and mistrust, and they do talk about PTSD in parents of children who are in an ICU, and again, my heart goes out to both you and your husband, but then I also think a little bit about your daughter.
Can I just tell you how much I love that you asked that question and how much I appreciate that? It has a huge impact on her, and I think the siblings of kids that have chronic health conditions walk around with a lot of stress. Some of them walk around with trauma, medical PTSD, which my daughter does, that was unrecognized for years. And finding care for that is excruciating. And then there's the whole other journey of having them agree to get care for that is also excruciating. And I tell a story, I think I wrote a blog post about this, that, you know, when Zach was in the ICU, we didn't know the impacts that it would have on our family of what would happen to him. And it's not just the ICU experience, it's the repeated him going to the hospital in the middle of the night, and it's the screamer migraines he has. It's Evie not knowing when he gets sick or he can't go to school. It hasn't been to school for 3 years regularly. It's the living with the uncertainty of rare disease. And she's not, you know, she hasn't been 3 years of therapy like me. So she doesn't, you know, she's young and she doesn't know how to unpack all that stuff. She sits with it. But that ICU experience was a lost opportunity for the system to say, and a friend of mine that I met on Twitter, because that's where I meet everybody. Everybody go on Twitter, okay? She had a very different experience when her daughter was in the ICU. There was a card that said, you might experience these symptoms months after your child is here. This might be PTSD, and these are places you can go, the kinds of places you can go for care. And your family might experience them. Had I known that that was a possibility way back then when Zach was 6 and he's now 17, I would have looked for care so much earlier for myself and for my family. She was 4 when Zach was in hospital, and I didn't understand that she could get PTSD. I didn't understand that I could, never mind her. And it was, you know, PTSD, early intervention makes such a difference. So she's been living with it like her whole life. Sorry. It's going to be hard for her. You know, you talk about adverse childhood events, and that sucks. You know, and for her personality as well, like she's a different kid. You know, it's funny, Zach's the one with the rare disease, and he's like the most mellow person, and he's like, you know, whatever. It'll all work out in the end. The rest of us are like, this is why I want things to change, because it's not Zach's rare disease. I mean, obviously, it impacts his health in very negative ways. Changing the system wouldn't necessarily change how he's doing physically, but changing the system and having access to supports would change the trajectory of how our lives are impacted. It would make such a difference. Thank you for asking that. I really, truly appreciate that.
Are there any other comments or questions? All right, we'll go ahead and adjourn this session. Please join me in thanking our panelists again.